Good evening and welcome to my YouTube channel Pain Free Partha. And almost 400 to 500 slides are freely available and downloadable and editable in my website painfreepartha.com slides. And my pranams to Professor M. Ravi Shankar, who is the Director of E-Learning in Mahatma Gandhi Medical College and Research Institute, Pondicherry. So what is this costoclavicular space? The costoclavicular space is located deep and posterior to the midpoint of the clavicle. They thought it may be a better place to inject in the infraclavicular region rather than the traditional paracoracoid space. So the name itself is costoclavicular. Costa means rib and clavicle. This is a space in which cords are there. It is anteriorly bound by the clavicular head of the pectoralis major, subclavius, and possibly by the intercostal space between 1 and 2 ribs and serratus anterior by the side. This is the axillary artery, which is medial. Vein is further medial. This is the costoclavicular space. This is PMJ and subclavius are anterior and rib and intercostal space are posterior. Now again I am telling this is the costoclavicular space, pec major, and this is the brachial plexus sheath, costoclavicular space, second rib, first rib, intercostal space, serratus anterior. We can also see the axillary artery, axillary vein, and these three cords in the costoclavicular space. We can see the pleura so distant from here. The pleura is so distant from here, and there are muscles, and serratus anterior is here, and subclavius and pec major are there. What are the indications of? It is used for surgeries usually distal to the shoulder, elbow, forearm, and hand. Not possibly for shoulder because of some conditions, because the suprascapular nerve may escape. Catheters are possible, and pain conditions like CRPS, sympathetic pains, the catheters are used. These are the indications. Previously, the supraclavicular was thought of as spinal of the arm. Now they are fighting with either costoclavicular can also be designated as spinal anesthesia of the arm. This is the place we know. This is the intercostobrachial nerve space, which is T2. So we cannot block this. So now we can see this is the clavicle and pectoralis minor, clavicular branch. The space is here. Now, this is one of the blocks where we go to under the clavicle, below the clavicle, and under the clavicle. It is not supraclavicular block. It is a type of infraclavicular blocks. Okay. The rate of success, onset, and complications are similar in obese and non-obese. So obese, okay. Children, okay. Emergency, okay. Non-operating room, okay. Pregnancy, okay. So these are all the tips of costoclavicular approach to brachial plexus. Now, what is the technique and position? Patient in supine position, head turned away. You may have a small towel here so that this space is slightly opened out. Abducted to 90 degrees to produce. See, otherwise, how can you place the transducer? Slightly abducted here. Now, if the PMM is seen and infraclavicular, if the PMM and subclavius is seen, then we are going into costoclavicular. Okay, this means both pectoral muscles. We are infraclavicular. Go slightly medially. We will go away with pec minor and PMJ will be seen. Subclavius will come. Maxillary artery. Go lateral. We can see the cards. That is the costoclavicular space. Yes, midpoint of the clavicle, just go and then go slightly medially. Or sometimes some people also may go vertically. This is the three cards. Now you can see The lateral cord, medial cord, and posterior cord. The posterior cord is not posterior. Just think of that. Now, as soon as you keep the position, trace the axillary artery. This is very important. We have to see the axillary artery. Vein is next medial to it. And if seen, see the pectoral muscles. Then go medially. If the cephalic vein or the thoracoacromial artery is visualized, then the transducer is lateral to the CCS. Go medially. Get it medial and get it under. If the bone hits, then you need to go. Normally, the technique is from lateral to medial. Sometimes you may also go medial to lateral in plane technique. We may go under the clavicle, medially go under the clavicle to see the axillary artery. So this is supraclavicular, this is costoclavicular. Almost like, see, it is coming, the brachial plexus is, this is clavicle, supraclavicular we are seeing from here, and costoclavicular we are seeing from here. Tilt the probe slightly so that the ultrasound beams point cephalad, allows the axillary artery, vein, and the cluster of cords. Slightly rotate. Yes, we can see probe cross-sectional view of the artery. So, most important three, artery should not be flat. Full cross-section of the artery. If that is seen, then we are okay. From lateral to medial in plane, get it in the space, identify the cords and give 20 ml. Usually the depth is 3 to 4 centimeters. The septae may be there. They say there is query or doubtful clinical significance. If we hit the bone, then try medial to lateral or out of plane. Sometimes the out of plane may be easier as the needle visualization may be difficult in plane. Now I'm saying here, I am going like this. So my needle has to track in the same plane of the ultrasound beam. It is not like this. So it will cross and go away. So if this thing is there, then we can easily put. If that is slightly go under, it is very difficult to visualize in plane. Sometimes we may go out of plane. So this is the anatomical basis of the costoclavicular space. This is the lateral cord. This is the deltoid muscle, the axillary artery. Pec major is retracted. This is what is a costoclavicular space. The action now normally 20 ml. The action starts at 5 minutes and complete block can be achieved in 25 minutes. That depends upon what drug you use. Sensory, and there are a lot of differences because 20 to 30 minutes maybe with mixture or with bupivacaine alone at all. There is some difference. I usually give 3-point injections. This is the axillary artery, give here and give here and give here. So 3-point, make it 20 ml. That is usually sufficient. So if you give 2-point, the success rate injection rates from 97.5%. Single to double, see the premier. So this is what is a costoclavicular space. We can see the medial lateral cords and the posterior cord. Now if your costoclavicular cords are not well seen, what I do is I give some 3 ml or 5 ml in the supraclavicular space. Now you see the brachial plexus in the costoclavicular. After I have given 4-5 ml in the supraclavicular space, now you see the costoclavicular is well seen and give 15 ml here. That is what is published by us. Pre-injection technique to identify neuro. Now you can also cut down the subclavius and give here to see what is happening. So then we can find out these things and give 2-3 injections here. I prefer here, here, and here so that it is covered well. This is pre-injection technique. Give some supraclavicular and see again the costoclavicular space. So what are the advantages? Cords are compact, consistent. They are relatively superficial, 3 to 4 centimeters. Away from pleura. We saw the pleura is so much away. The decrease in the number of needle redirections. More consistent diaphragmatic preservation. Where is the epidural? Where is the sympathetic chain? Nothing. Neurological complications? Low. Everything is comparable to other blocks, but Epidural is almost nil. Sympathetic chain is nil. Diaphragmatic preservation is excellent. Yes, it's as a bundle, three cards. The important problem is if the nerve has escaped before the cards, then it may not be blocked. That's the problem with supraclavicular, suprascapular nerve and the shoulder surgery and costoclavicular. So you see, there is something called costoclavicular ligament also. It may also prevent the injury. What are the critical structures in the needle path? Yes, medial brachial nerve, medial antebrachial, and branches of the thoracoacromial artery. Now we can see here. This is the MBC, medial brachial nerve. This is the medial antebrachial nerve. These nerves are here, and the lateral cord is here. Axillary artery is here. So when you pierce, there is a possibility of either the thoracoacromial artery branches or the MBC or the MABAC may get injured. And cephalic vein is there, go medially. Don't touch the cephalic vein. This meta-analysis of infraclavicular versus costoclavicular. Costoclavicular is sometimes called medial infraclavicular. So it is lateral, this is somewhat medial. Now you see the lung very distance. When compared to classic distal with comparable rates, volume set techniques matter because you cannot say just both are comparable because technique also differs. Now there is a big operation done before 5-6 years before. They have taken the pectoral flap and all. Now we cannot say where is it. Now what they have found out is instead of keeping the probe here, keep the probe like this vertically, you may see the cards like this. So then they have done the humerus surgery. Diaphragm sparing nerve block because already we have told suprascapular nerve is spared. That's a problem with shoulder, but diaphragm is splenic nerve is somewhere. The subclavius, axillary artery, three cards: lateral, medial, and posterior. Above is lateral, medial, and posterior is by the side. So give the injections local, and so that all the cards are completely soaked. The thoracoacromial artery is here. Now we can see here. Phrenic is extremely rare, maybe around 0 to 7% if you use a volume of 20 ml. So yes, there's a spare. There is a lot of confusion about because it spares suprascapular nerve. Shoulder surgery is difficult to do. Yes, in 87% of cases it occurs at 30 minutes. This is where we give and the suprascapular comes here. Now the cord level we give and suprascapular comes here. That is for shoulder surgeries. A lot of publications, postoperative analgesic efficacy of intraspinal versus costoclavicular. Similar outcomes with 0.5% levopipivacaine. Bayatol, yes, obesity, CCS is good. What they have done is, here you see a comparative study, they have used 35 ml with Dexmet, so it is very difficult to compare studies. Sensory botar blockade dynamics after an ultrasound guided single, see supraclavicular and costoclavicular. Both are okay, but phrenic sparing is better with CCS. What is space anatomy? Costoclavicular. Costo means rib. Clavicle means in between the space. Axillary artery is here. Above that is subclavius, above pec, and by the side is serratus anterior. Down is the first rib, second rib, and first, second intercostal space. Why it is important? It is as a cluster. All the three cards are cluster. Okay. And technique is midpoint of the clavicle, just go down and then slightly medially and go under the clavicle. You will see the axillary artery as a good cross section round. That is very important. Good cross section round. You can see lateral three cards. Technique is I used to give 3 ml or 4 ml the supraclavicular, get the cards very well seen, and give 3 sites injections in the costoclavicular space. Advantages, yes, I know, phrenic sparing and this thing. Shoulder difficult. Vascular puncture because cephalic vein will come. You have to go medially. There are 2-3 arteries which may come. Axillary artery is also there. So vascular puncture is a danger. So these are the two problems with costoclavicular. Problem with suprascapular nerve sparing, vascular puncture. This is what we should be careful about. YouTube, Pain Free Partha, subscribe, listen in full. Thank you very much for your time.